Welcome to Doctors on Call. I'm Jenna Miller. 1 in every 4 deaths in the United States is caused by heart disease. Coronary heart disease is the most common type. You may experience chest pain, lightheadedness, shortness of breath, or nausea as a precursor to a heart attack. While heart disease is the #1 health threat in the world, the good news is most heart diseases can be prevented with healthy lifestyle choices. How do you know if you're at risk? We'll find out more today on Doctors on Call as we discuss heart disease with our guest, Dr. David Battin.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from CAMCO, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Closer Regional Hospital, experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.
Dr. David Battin received his medical degree from the University of Kansas Medical School. He completed his residency at the University of Kansas Medical Center in Wichita and his fellowship at the University of Tennessee Health and Science Center and William Beaumont Hospital. Dr. Battin is board certified with the American Board of Internal Medicine, Cardiovascular Disease, Nuclear Cardiology, and Interventional Cardiology. He's a member of the American College of Cardiology, Society of Cardiovascular Angiography and Interventions, and American College of Physicians. Dr. Battin joined the Mowery Clinic in Salina in 2010 and has clinical outreach locations in Abilene, Clay Center, and Concordia. Our phone lines are open, toll-free, 800-337-4788 if you have any questions tonight regarding heart disease. On today's show, Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you so much, Dr. Battin, for coming back and joining us. Let's go ahead and start. I always like to start off with what's new and innovative in the heart disease world.
I think structural heart disease is the area that is still kind of leading the way in innovation as far as therapies and strategies to aid and assist patients with specifically valvular disease. It's just becoming easier and more available for patients with complex heart disease, or not even complex in a lot of regard, but therapies in the tricuspid valve position and mitral valve position are becoming less invasive and therefore more available for a larger population. So I think that space is turning over and getting safer and better, and it's really exciting. And of course, the aortic valve space has been around for a long time and is being offered at more places, bringing those services closer to home. And we've been doing that in Salina for a couple years now, along with left atrial appendage occlusion with the specific Boston Scientific product, the Watchman. I've been doing that for several years now. So that space has really, I think, been still the most exciting and most innovative.
Sure. Can we talk a little bit more about the aortic valve and what that is?
Yeah. So the aortic valve is the valve that, basically a one-way check valve that is in between the left ventricle and the rest of the body. And when that gets diseased over time, after rotating around the sun for a few decades or so, that valve becomes calcified or scarred, or a combination of both, and it doesn't open as well. And patients will have symptoms of shortness of breath or chest discomfort or exertional type fatigue. And they'll also be told that they probably have a murmur, which is a noise that a physician or care provider would hear on exam. And when that gets bad enough, it needs to be fixed. And the transcatheter aortic valve replacement, that is replacing the valve from usually a leg artery, has largely replaced the open surgical procedure as the preferred strategy and preferred therapy.
Okay, very interesting. We're going to go to the phone lines. We've got Kathy on the line from Hutchinson. Hi, Kathy. Go ahead with your question for Dr. Battin tonight on Doctors on Call.
Well, thank you, Dr. Battin, for taking my call. 2 years ago, when we had several days of extreme temperatures, like 100 and some degrees, I was mowing my lawn and finished the backyard. I was working on the front, and all of a sudden, it was like a bam. It's like instant fatigue, weakness, a little bit of nausea, a little bit of unsteadiness. I was able to finish mowing my lawn in taking paths and then taking a break. I was able to finish it, and I went to bed for a week. And then in July, when I was getting having pre-op done, they discovered that I had had a heart attack. I had no chest pain. I had no back pain. No numbness in the left arm. So I would like for you to please, because I've been telling a lot of women about my symptoms as what you usually hear, and I would hope that you could address this and educate the women out there tonight. Thank you. Bye.
Yeah, certainly. I mean, that comes up all the time. I mean, honestly, every year that I'm here, I think we bring that up, and anytime I give a talk elsewhere, there's certainly the most common chest discomfort, shortness of breath, etc. But definitely women are more likely to have uncommon signs and symptoms, and such as what our caller described, nausea, extreme fatigue, sweaty, etc. I think the key there is that something occurred, and it was wildly out of the normal. And I as someone that's listening to that, I know that, oh man, there's clearly something going on that's probably unstable, and honestly, quite lucky to survive something like that. So, anytime you feel an abrupt change that lasts 15, 20 minutes, etc., no matter what it is, and it's got you down, you need to get it checked out. And there's so many different symptoms that could actually be a heart attack. It's not always easy to know unless you're being evaluated if that's what's going on. So yeah, it's not an uncommon story, but certainly common for us in the medical field.
Sure. And kind of going off of that, how important would you say once you get to a certain age that it is to get to even your primary care physician for those wellness checks?
Yeah, I mean, I honestly, you need to start way younger than when we start. You should have your kind of baseline blood pressure and labs as far as cholesterol at 25, and from there you kind of, whatever those results are would dictate what kind of follow-up you would need moving forward. But particularly blood pressure, having some idea of what you run, whether you have the condition of primary hypertension or not, we should check that periodically, whether at home, which is an ideal setting when you're relaxed for 15 minutes or whatnot, or at the store. But the key is to have had an opportunity to sit down and let your body kind of auto-regulate, and knowing that you just came off the street or ran into the store from the street or whatever. But high blood pressure is a leading condition, a leading cause for heart disease, and that is all comers of heart disease of the heart muscle, as far as heart failure, disease of the blood supply or the heart arteries. It's just a major player.
Let's talk a little bit more about that with blood pressure. Is it true that not all blood pressure readings are created equal?
Yeah, it gets a little frustrating, and there's going to be some variance. I think the blood pressure is dynamic. It's going to respond to situations. It's going to respond to what you're doing. It's going to respond to stress. So if you've been at the store or you're running, your blood pressure is going to go up. That's what it's supposed to do. But it's not supposed to be up when you're at home on the couch necessarily for 5 or 10 minutes. And you may have some variance in the arm, you may have some variance throughout the day. It shouldn't be a lot of variance, and basically if you keep a log, you don't get freaked out about one individual reading. What we're looking at is basically what are the trends? Are you more normal than abnormal? Are you more abnormal than normal? And then the discussion occurs as far as management.
And at what point does a person need to go to the emergency room?
Yeah, I think as far as concerns about the heart, whether there's concerns about a heart attack, I say any symptom that one is having that is occurring basically in this general vicinity, and no matter what it is, chest discomfort, people use different terms to describe essentially the same thing. Maybe asked if they're having chest pain, and they'll answer you with a straight face, no, it's not pain, but it was a pressure. Okay, well, to me, I don't make a distinction, but lots of other people, patients, etc., do make a distinction. So pressure, nausea, shortness of breath, feeling sweaty, vomiting, oftentimes it's shoulder or arm pain, shoulder blade, between the shoulder blades, things that kind of radiate into the neck or jaw or ache. A lot of the words that I've heard over the years that are describing that kind of syndrome. Now, it needs to have, when it has lasted for longer than that kind of 10 to 15 minute range, that's really in that realm of unstable and should get checked out. Stuff that comes on with activity and gets better with rest, and that more insidious type process, that's more of a stable condition. You got time, you can call your doctor, you can get that evaluated. It doesn't necessarily require an ER visit.
And you mentioned that Kathy was lucky to have survived what she did. Would she have fared well to get herself to the emergency room at that point?
Yeah, ideally, yeah. We're all, vision's always 20/20 when we're looking back like that. But and I think early treatment for heart attacks portends improved outcomes, improved survival, improved functionality. That's why we spend so much time focused on the logistics of heart attack care and trying to do it as safely and efficiently and as quickly as possible.
Okay, let's talk about what coronary artery disease is.
Yeah, so that's fundamentally what we've been talking about for however long we've been talking is a disease of the coronary arteries, and we've been spending a lot of time talking about kind of the unstable syndrome, heart attacks and symptoms at rest, but one of the more common as well is coronary artery disease, or when we get plaque buildup inside the heart arteries, and that is definitely more of an insidious process that occurs over a long period of time, and certain risk factors lead to coronary artery disease, such as high blood pressure, high cholesterol, smoking, diabetes. Patients with that condition, where it just kind of builds up slowly over time, notice problems with activity. They'll have exertional type problems such as shortness of air, or chest discomfort, or even exertional type fatigue. Basically, they're not able to do what once they were able to do. And a lot of individuals will adjust down, saying that, well, maybe it's because I'm 80. Well, not necessarily. If you're 75 and used to mowing your lawn, and now you're 76 and you can't, I don't know that that's necessarily age. It might be something else, so it's something to explore.
Okay, we're going back to the phone lines. We've got Yvonne on the line from Great Bend. Hi, Yvonne. Go ahead with your question tonight for Dr. David Battin.
Thank you. Everybody's concerned about high blood pressure, and sometimes, especially when I'm relaxed watching TV, my blood pressure goes really low. How serious is that, and can that cause a heart attack also? Thank you.
Yeah, it's not. If anytime you're having symptoms, dizzy, lightheaded, feel like you're going to pass out, and you get a really low blood pressure reading, that would be a reason to be concerned, but it's not really going to lead to a heart attack. Now, there's several caveats, obviously. I don't know anything about your other health history, whether you're taking medications for high blood pressure or if you have, congestive heart failure and taking medications for that. Sometimes, all those medications that we use for congestive heart failure, I should say most, do cause the blood pressure to go down. And so it's very common to have a blood pressure, the top number, the systolic reading would be 80. It may be 80 over 50 or 80 over 40. And the individual is completely asymptomatic. That is okay, that is fine. They're obviously perfusing. If you're able to talk and mentate, then the blood supply or the blood flow to the rest of the body is fine. So I don't get really ever too bent out of shape about low blood pressures unless people are symptomatic.
Okay, back to the phone lines we go. We've got April on the line from Salina. Hi, April. We are ready for your question.
Hi, I'm calling tonight to ask the doctor what his opinion is of all these young, healthy athletes that have been suffering from heart attacks in the past year.
So, okay, I assume we're talking about, yeah. So I don't think the incidence isn't going up. Certainly, the Damar Hamlin case garnered a tremendous amount of attention as it occurred during a live NFL event. Fortunately, it's not very common. And in high school athletics, it's about 1 in 750,000 participates. The issue is that these are young individuals, and we don't want it to happen to any of them. So I think that the importance of having an action plan at every institution needs to be highlighted. I think if our kids that are going to high school or college and they're participating in any kind of athletics, it doesn't really matter. Even in gym, there needs to be an AED, which is the automated external defibrillator. These devices need to be readily available. People need to know where they're at, and there needs to be an action plan where the institutions, if something like this happens, they know what they're going to do, and they need to rehearse it at least every year. And I think what can be garnered from those, in some cases very tragic events. In the case of Damar Hamlin, it wasn't, but in others, they're not so lucky. It's super important to recognize that they suffered a cardiac event and that early therapy is treated, because usually what happens is that their heart goes into a rhythm that's quite frankly not compatible with life. And if early resuscitative efforts aren't undertaken, then their likelihood of survival goes way down by the minute. And doing CPR, high quality CPR, and early defibrillation, usually with one of these devices, is what will improve survival. So, I think I'm glad you brought that up. That's an important point. And I think that high schools and any place, the YMCA, it doesn't matter, Genesis, etc., they need to have these, Walmart, they need to have these devices readily available.
Very interesting topic. Okay, we're back to the phone lines. This is Daisy on the line from Russell. Hi, Daisy. Go ahead with your question for Dr. Battin.
Hi, Dr. Betts. I have a 80% blockage on my aorta in my torso region, and the surgeon that I saw is not the one that did all the tests on it, the MRIs and the CT scans, or, he isn't the one that found it. But he just checked my pulses on my feet and behind my knee and said, "You have good blood flow. We'll see you in a year." Should I take that as an answer, or should I get a second opinion?
Yeah, that's That's complicated. So I think in that regard, assuming that you and I are speaking the same language, you have a narrowing in your probably descending aorta, and that's the main blood pipe coming down, and probably located in between here and here. You use the word thoracic. So decisions that would be done by a vascular surgeon, most likely. That procedure, definitely not something that I would do. And it's going to come down to, once again, symptoms. And I think not only, checking pulses in your lower extremities, but checking blood pressures in your arms and your legs, and discerning if there's major variations. But I think at the end of the day, if you're not comfortable, then a second opinion's never going to hurt, and may provide you with a little bit more information than what you got. But he may not be wrong either at the end of the day.
Every once in a while, we'll talk about second opinions here. What do I've had several people say, oh, I don't want to hurt my doctor's feelings, so I don't want to go to a second opinion. How do you feel about second opinions?
I mean, I don't think you should ever be bothered by a second opinion. I mean, it's really not personal. It's not, as a physician, it's not about me. It's about the patient and what makes them feel most comfortable. Maybe as a physician, we weren't telling them what they wanted to hear or what they needed to hear, or it was such a shock or whatever. I don't know, but I mean, I think if I was, just as an individual, that if I were suffering a condition and I had any question, and some therapy or was being brought forward, I don't have a problem with it at the end of the day. That's a lot of words for saying I don't have a problem with it. I think it's a good idea. Whatever that makes you feel most comfortable.
Okay. Great thinking. Okay, so I wanted to go back for a second to April's question regarding the young athletes and the heart events. I wondered if you've seen an increase in younger people coming into your clinic.
No, not because of the events. I guess not because of the increased, exposure, I should say, awareness of such a kind of a major thing that took place in front of everybody. I haven't really seen an increase or an uptick in that regard. I mean, there's always a handful that come in for different reasons, but not just because of that.
Mm-hmm. Sure. Let's talk about how you determine when let's talk about stents or a bypass, when you determine a patient needs those.
Yeah, that's going to be, I use this word a lot tonight too, symptom driven for sure. In general, stents, particularly ones that we put in the heart arteries, for those individuals that are stable, we're talking about patients that try to go and mow the lawn, for an example, and have chest discomfort after about 3 rounds, and they stop and it gets better. They go again and then you have discomfort and stop and it gets better. So in that instance, if you place a stent, then you could definitely help them. Or if they have multiple blockages in multiple locations, doing bypass surgery and totally rerouting the blood supply to the heart would improve their quality of life. And that's the same for stenting as well. It improves the quality of life. It doesn't necessarily improve the quantity of life in those scenarios, but it definitely improves the quality of life. Medications can as well, but there has always been in the trials a large crossover of individuals that the medications just didn't cut it. So, a quarter to a third will always cross over to want to have that therapy done. In the cases of heart attacks, early recognition, early presentation, and early treatment, stenting, etc., improves survival. Not only does it improve quality of life.
We have just a little bit of time left, but if a person is diagnosed with heart disease, let's say, what are some steps that they can take right away to try to get themselves on track?
Yeah, it's 1 through 10. The first aid is don't smoke, and if you do smoke, stop. So I get to say that every year. Wouldn't have been a doctor's on call if I didn't get a chance to say that, so thank you. The other is identify the other risk factors. High blood pressure, for example. High blood pressure needs to be recognized and treated. Super important. High cholesterol, and we want the bad guy cholesterol, the LDL, to be less than 70 and ideally less than 50 in most cases. Diabetes, if that is present, control it. Diet, exercise. That it is really a modifiable problem in most cases. Blood pressure is also very modifiable. If you're overweight, and most people are, really got to control the calories in and try to work on burning some of those off. Exercise 30 to 40 minutes a day, most days a week. Definitely helps as well. Controlling the stress, always easier said than done. But figuring out kind of stress reduction strategies through exercise or yoga or meditation or throwing a tennis ball against the wall, whatever it is.
Okay, very good. Thank you so much for coming back and being
Thank
our
you.
guest on Doctors on Call. Next week's Doctors on Call, we'll be discussing depression. You can email us questions for our next show at doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from Camco, the state's only Kansas-based medical liability provider, serving medical professionals and advocating for the health for all Kansans.
Russell Regional Hospital. Experts, neighbors, friends.
Your family is our family. Staff at Smith County Memorial Hospital wants to set the standard of excellence for healthcare in north central Kansas.